the others, it's easier to do in the prone position. So if you pull anything from T1 down through L5, go prone, or even including the pelvis, PI ilium, PIR sacrum, any of those, you're going to put the patient down, you do your bony palpation first. From T1 down to L5, all your palpating form bony palpation are spinuses and transverses. In the lumbars, it's spinuses and mammillaries. The main thing you feel for, of course, is spinuses. It's the most accessible and easy thing to feel on your spine. So you make sure you do it on skin because you don't want to get points off for doing it through clothing, and that everybody does that for some reason. And I say this every time we do a review. Do it on skin. Don't do it through the gown or through the underwear if it's an easily accessible point. So no point losing points for no reason. Palpate for the spinous processes. If you're doing a region, you can work your way down the spine in your spinal exam, feeling for spinous processes. You look for anything that's to the left or to the right. At the same time, if you got your fingers lined up, you're feeling the area where the transverses are. You're looking for anything that's sticking out, superficial or depressed. You're also, when you're doing this, you're looking for any edema or tightness when we roll down the spine. That's all in your prone exam from T1 down to L5. And you can analyze all that stuff just by doing a few passes up and down the spine and focusing on bony or hard tissue or soft tissue. So if you pull up a T5 or an L5 and it's a PR, what we want to hear bony palpation-wise is, oh, the spinous would feel bony palpation to the right of what? Up to the one below. The transverse or the mammillary may be superficial on the opposite side. That might be something to feel. And I might say, all right, show me where the transverse would be. So make sure you know where your transverses are in the thoracic spine. 1 through 4 and 9, or 1 spinous up and over, right? So make sure you know those, because definitely if you get a thoracic, you're most likely going to be asked, show me where the transverses are for that guy. And we want to see that you can locate the spinous and come up the right amount. Don't forget, if you're looking for T6 or T8 or T9, check your landmarks. It's easiest to do your VP identification, lay the patient down, work your way down from the VP, and then check it against the inferior angle of the scapula, the bottom of the rib. If we see you do that, even if you're off, you're in a good place because I know you're being thorough with your exam. So that's good. Okay? Some patients are more challenging than others, and that's just the way it's going to be, especially in the beginning. But if you're going through the right routine, then we're not worried about it because eventually you get it. So that's my thoracolumbar bony palpation. I'll do muscle palpation. It's easy from T1 down to T12 because all you're doing is putting your fingers on the sides of the spinuses and looking for rotators multifidi, serratus posterior inferior, serratus posterior superior, all of the muscles that come out of the spinous process. That's all you care about because spinuses are the lever arms for motion. So all I want to know is it tight next to the spinous. If it's tight next to the spinous, it could indicate a listing where the spinous is opposite. Spasm on the right, trying to pull the spinous back. I give it a left listings, PL. That's all you got to do. Stay next to the spinous. Don't get out. The most common mistake that's made here is I say, well, show me where you would find those muscles, serratus, rotators, multifidi, and you wind up out here on the rib. It's next to the spinous, no matter where you are, because that's all you're doing is trying to figure out what's going on with the spinous. That's your muscle palpation for that region. Questions on that? Thoracolumbar muscle palpation.
Can you just run over what the levels are for like scapular spine, inferior angle of scapula, iliac crest?
Okay, in the prone position, the inferior angle of the scapula comes in usually at T6. T6 is going to be at that level, maybe above it, almost never below it. Okay? In the seated position, it winds up being T7. The last rib, I don't know whether you learn to just come over towards the midline. That's usually going to be at L2 or L1. But they also, I think, and tell me if I'm wrong, they also teach you trace it up to the T12 spinous process. Somewhere you lose it, but you extrapolate it in, and that's T12. T12 is usually a pretty easy one to feel too. Okay? So you got T6, T12 can identify the crest of the ilium in the prone position usually comes in at L4, L5 interspace. So those are your main landmarks that you're going to use. And then your VP. Last movable segment, inflection extension, that should be identifiable mechanically as the C6 segment. What? The spine of the scapula, I think
it's 4.
I don't use that little one. T3 or 4. So I can't tell you exactly which one that usually is because that's you guys know which one? It's 4, T4.
Let's count.
What's that?
Let's count them.
Let's count them on you. What if you're not? What if you're atypical?
I am atypical.
Now you're abnormal. Yeah, I get his a little higher than that. The other mistake sometimes people make is when you find the inferior boundary of the scapula, bring your arm back behind your back. That's to locate the scapula. Then you return it, go back to normal, because it's going to descend. Then you find your inferior. Then you find your T6. Don't find it when they got their arm back. Okay. Any other questions? Thoracolumbar. You come down to the pelvis. The pelvis, the bony palpation. Yes.
Are we motioning thoracics?
We are going to, but I'm going to do all my bony palpation pelvis first. Bony palpation in the pelvis is we want to see that you can identify the SI joint. I'm particularly interested. Can you show me where the top and the bottom of it are if you pull a pelvic listing? To identify the superior boundary, inferior boundary, SI joint, and if you put 3 fingers around the PSIS, you essentially have done that. That's the SI joint, and that's pretty much the top and the bottom.
We can show you like that.
Yeah, you could do this, and then I'm gonna put my fingers right on top of yours and say, okay, what's medial to your, what's lateral to your fingers? Well, that's the PSIS, and so your fingers are right in the SI joint. And then I might say, well, what if you find tightness or edema at the top or at the bottom? What might that indicate? So the PSISs are a bony landmark. Second sacrotubercle and the base of the sacrum are a bony landmark. Apex of the sacrum can be through clothing. That's a bony landmark. Ischial tuberosities, bony landmark. Okay? So any of those we could ask you to locate, especially if you pull a listing down in here. Those are your bony findings. So if it's, if it's a PIR, or let's say a posterior rotated sacrum on the right, I'd want you to be able to know that second sacrotubercle might palpate bony-wise closer to the PSIS on the left, further than away from the PSIS on the right. And that's also, this is the same thing you can see on x-rays. All your bony palpation findings are the same exact things you visually analyze for on x-rays anyway. So to know that, that's your bony. Muscle and ligaments we do in the lumbo and the pelvic area. Of course, we got our large erector spini group. We just look for tightness in there. That's easy. Go right across. The 3 ligaments that we do are the sacroiliac joint ligament, looking for tightness and or edema. The sacrospinous ligament, tightness. Could be edema, but mostly we talk about tightness, sacrotuberous. So those are the ligaments that we want to see that you go through to identify if you get a pelvic listing. And then we might say, well, show me where the sacrotuberous is. And you put your finger on the sacrotuberous, and I back it up to see if you got it. All right? So, sacrotuberous, be tight. They have a PI on the left. We'd like to find a nice tight sacrotuberous
We
ligament.
need to do that bilateral.
Yes, that's the other thing, is you do it bilaterally. Let me mention this too, because that's a common mistake. When you do motion, you do muscle, you always, we're going to watch to make sure you're doing it bilateral. You're comparing the left to the right. Even though you might know what the listing is, because we gave it to you, we don't want to see that you're just doing everything on the left. We want to see a thorough exam first, and then we're reporting of what the possible findings could be. So when I do my palpation, I'll make sure I do both muscles, left and right erector spini, even if they have a PI. We get certain things on the left, PI on the left. I'm palpating both SI joints, top to bottom, palpating sacrospinous, palpating sacrotuberous on both sides. And then you say, okay, this is what I have. On the left, I'll find this. On the right, I might find this. Okay? Some of the pelvic listings don't have a lot of findings on them. AS ilium is not going to have barely anything. Don't try and make stuff up. Just say it's AS ilium. Got barely anything. That's what we want to know, is that AS ilium's got barely nothing for, it's not, you're not going to get a lot of AS information on palpation. Might look that way on the x-ray. There's a lot of stuff on the x-ray you can get more than palpation. There's no motion finding for an AS ilium that we do. We want you to be able to, know that. Sometimes you guys, not you guys, of course you guys went through this. Other quarters before you, they pull an AS ilium and start making stuff up. And then, it tells me that you don't have a good grasp on what you got. If there's nothing there, you say, there's nothing there. I know there's nothing there because I studied it.
So stabilize the sacrum and having them extend the thigh, that's not...
You weren't taught that as part of an analysis for an AS ilium.
No, okay.
You were taught that as part of the package of looking at the leg checks as an indicator of, are they subluxated or are they not subluxated? Can that be used that way? Yeah, but we're not expecting you at this level to start thinking of other ways to analyze a joint. You follow me?
Stop thinking.
Well, you know, there's a point where we have an expectation. Some of you may have thought beyond it,
Dumb it down.
but if you start going down that road, invariably you may not have a full picture yet, and you're just gonna, you're more likely to mess it up because you're still early in your training. So I say don't go down a road. Just do the basics. 'Cause that's what we want to know. Are you safe to unleash on the public? Teenage mutant. All right. Any other questions on that?
I think Mary had a question.
Yes,
No,
question?
it's not our bony, though.
What's that?
It's not our bony.
Okay, so then we're gonna do motions. Go ahead and sit up. Motion palpation. Again, you're doing everything bilateral. I'm gonna do my motion flexion, motion palpation, thoracolumbar is flexion, extension, lateral flexion, rotation. Thorough analysis. Even if I'm doing one segment, flexion, extension, lateral flexion, left and right, rotation, left and right. You get some freedom to determine how you're going to handle the patient. What we're going to be looking for, do you have control of the patient? If they're small and you're big, or you're big and they're small, no, or they're big and you're small, you're going to handle the patient a little differently. Most of the time, I think, you guys go ahead and cross your arms, grab your shoulders. This is the most common way of handling the the thoracic region and binding the patient up. You always want them to grab something up here and be bound up, because you can control them a lot better no matter where you grab them from, as long as they're bound up here. You can do flexion and extension. Did you have a question? You sure?
I have one about
Always, man.
I have one about cervicals. When you palpate muscles in the cervicals, do you have to palpate on one side and then move to the other side and palpate with the other hand?
No, you don't have to, as long as you're palpating both sides. If we see you do everything like this and the thumb's hanging out here,
Yeah.
I know you didn't palpate the right side. You follow me?
Yeah.
But if you're in there and it looks like you're doing both sides at the same time, and most of the time I'm just going to assume that's what, you know, it looks like you're doing it, you're doing it. Okay, so drop your head down, your arms. So flexion and extension, same thing. You want to get control of the patient. You're going to do extension. We want to know that you can tell me what the kinematics are in extension. Spinals are closing down, right? And in flexion, collapse down. There you go. Flexion and extension. So you do flexion and extension. You're going to do lateral flexion. Make sure you're in lateral flexion. The heel of your hand goes into the ribs in the thoracic region. Create a pivot point so you can laterally flex them nice right under your fingertips. And make sure you do both sides. All right? You're not going to be required to come to the other side necessarily. But if you're doing this, that's really not as good as doing this, because I can push the hand in. And it's rare that I've seen anybody do it well, being on the opposite side of lateral flexion. So I'm going to tell you all, switch sides and do a lateral flexion towards you all the time.
But do we have
And
to,
you know you're doing it thoroughly, yeah.
that's my question. Do we have to do it on the same list? Like, say for instance, I'm doing T5 and doing lateral flexion. Do I immediately need to go over to the next side and do it?
I would make sure you do both sides, whether you do a thorough exam on the left and then a thorough exam on right, but you do both sides. And I would switch sides, all right? Because if you don't, you are risking losing points for not having as good control one way as you do the other way.
So in the thoracics, the kinematics kind of, the upper thoracics follow the cervicals, and the lower thoracics, they kind of follow the lumbars. What we've kind of been taught. At what level are we drawing the line for lateral flexion, I mean?
The reality is, if you, the studies they've done is, and we talked about this in biodynamics too, as soon as you get below T4, you can have the coupling completely switch over. You just don't know where it's going to switch on any given person. So what you look for clinically is T4 works, up till T4 typically works like a cervical. From there down, there's going to be a switchover point, but whatever this patient is doing in left lateral flexion, I expect at that segment level to do the same kinematics in right lateral flexion.
Okay.
Flexion and extension are always the same, and you do the same thing with rotation. Whatever they do in left rotation, I expect in right rotation. And wherever the coupling enters in, you know, that's what I'm just feeling for. That's why we always do left and right. Feeling for an equivalent range left and right, no matter what the coupling is. Now, because the joints change at T11, typically from T11 to T12, you're going to get the change over into the lumbar kinematics. That's also normal too. But the no man's zone in between can be highly variable. So that's how you deal with it clinically. So what does it tell you as far as the listing? Well, it may not. motion palpation in that area, especially if you're going to use some sort of rule for finding a listing, it's tough. The main rule is, remember, we said there's two things. If it's restricted, that's a good indicator that segment's subluxated. That's common to every technique, looking for restriction. The second thing is, well, what direction is the restriction? That'll give you another level of information, but it may not be as clear as I got the segment level nailed down. Okay?
Could we see left lateral flexion again?
Okay, so left lateral flexion, grab your shoulders again. In left lateral flexion, the thoracics, I'm putting my heel and my hand in the side of the ribs because I want a pivot point. I don't need to bring him over like this because he's pivoting all the way down here. I just need to get the pivot in the segments that I'm looking for. So I'm kind of pushing in and getting lateral flexion at the point that I'm palpating. My fingers are on the spinous processes. Same thing here. Fingers are on the spinous processes. If you're looking at T7, you make sure you know you're on T7. You might need to count down again from the VP once you get them in the seated position. Occasionally, some people lose points because they just get in there and start doing it, and they're not on the segment we asked to analyze. And you start thinking about other things. You know, am I doing it right? And you just don't pay attention to the segment you're supposed to be analyzing. So that's lateral flexion, and then rotation, which isn't going to tell you much anyhow, but you're going to make sure make sure you know what the kinematics are. It's always the same kinematics with rotation. The front of the spine is going towards the side of rotation. Essentially, the spines go opposite the side of rotation. Whether there's a coupling there or not, rotation gives you rotation. You get to the lumbars, you may need to switch how you're going to handle the patient. Grab your shoulders again, and maybe you want, instead of holding their arms in the front, flex down, flex forward, collapse, okay? Do your flexion and do your extension. Stick your belly out, okay? You may want to get down behind the patient. However you feel comfortable handling the patient. If you haven't been practicing a lot, you really need to start doing that. Patients don't like to feel uncomfortable and insecure when you're doing it. Rotation, the same thing. Rotation is pretty easy. I do my left, I do my right. Bring them all the way around. And then lateral flexion is in the upright seated position, which means the kinematics in the lumbar spine are going to be opposite of the cervicals. Right? In some techniques, spinuses go towards the side of lateral flexion, bodies go away. Bodies are too fat to get in the cave outside of the concavity. If I did this to them, which in, for example, some techniques they do this and then they do lateral flexion, I get an opposite. I get what I have in the cervicals. You follow me? But that's not what we do. We do in the seated upright position. We look for the normal kinematics. All right? Is the other one invalid? No. It's perfectly useful, but it's a different kinematic. We need everyone to know and understand the same thing. Okay? That's lateral flexion. Questions? For the pelvis, for motion, there's only three things that we look for. PI ilium, an inferior sacrum, and something else. PI ilium, inferior sacrum. What is the other one? Oh, the INEX, yeah. Okay. So, for the INEX, we're looking for essentially the sacrum to go into nutation, be pressed forward, and put pressure on the PSISs internally. Make sure the patient gets to the end of the table, knees together, feet together, knees at a 90-degree angle. Ischial tubes on the edge of the table, sit up nice and straight, 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 straight. You put your fingers in the SI joint. You say knees together, knees apart as far as you can. Let them keep their feet together because that'll torque the pelvis better, and you feel that little forward motion. It's not a lot of motion. It's a minor amount of motion. If the back is rounded out, you won't feel it. Flex forward, right? That'll be resistive to the nutative process. You want them in the upright position. So if you feel restriction, when they separate their knees, you say, wow, if it's on the right, it could be an IN on the right, looking at an EX on the left. Either way, it's SI joint restriction on the right. That's exactly what we love to hear you guys say.
So if it's an IN on the right, you're not going to feel it go in.
Right. It's internally rotated. So the left side's externally rotated usually because they're connected, right? So when we have him separate his knees, this side, the relative motion will be less here because it's already closed down. Because you're comparing right and left. So that you say, it's restricted on the right. The other two motions are, go ahead and stand up. The knee raiser. I put my hands across the crest of the ilium, put my thumbs across the PSISs and the SI joint. Because I want to feel the relative motion of the ilium rolling across the sacrum at the SI joint. I say you can reach back and grab my wrist if you want for stability. Actually, Hold my
I-
hand. Hold my hand. Okay. So you say, okay, raise your right leg as high as you can and let it down. And you're just looking for the ilium to roll, PI. Left side, you compare left and right. If you find restriction, you say, I got restriction on the left. That could be a PI ilium. Popping and cracking is important too. Do it again. You still get popping and cracking? Where's it coming from? Is that coming from your knee? That's your ankle? Alright. And then lateral flexion. The lateral flexion is a check for an inferior sacrum. Right? We got a couple listings for an inferior sacrum. PIR sacrum, inferior posterior inferior on the right. AIR sacrum, which get some of your instructors, your health center faculty will be using that one too. Anterior inferior on the right, which is like nutation on the right, stuck in nutation. But either way, it's an inferior sacrum on the right. It does right lateral flexion. We told you guys, put your right hand down your right leg because that keeps the motion nice and tight. And his pelvis should go into right lateral, to nutation essentially, which is an inferior sacrum on the right. Inferior sacrum on the left.
You said inferior sacrum.
Yeah. When he does left, sorry. So he goes to left, goes to right. So the sacrum kind of does that nutative process when he goes in the lateral flexion.
So you just want to sound like the show.
So yeah, we do 3 fingers right across the base of the sacrum. So your fingers should touch right where the second tubercle is on the base of the sacrum. You're just looking for it to slide this way and that way.
So if you feel restriction in right, that's what inferior sacrum.
So we say, okay, this is what I'd love to hear you say. I said, so he has restriction, right lateral flexion. What could that mean? Well, that's restriction at the lumbosacral or the sacroiliac joint. So that could indicate there's something going on there. But basically, in right lateral flexion, we're looking for the sacrum to go inferior on the right. So it could be an inferior sacrum on the right, Doc. That would be awesome if you said that.
So just memorize.
Yeah, there's 2 components. And overall restriction tells you something's not right about that joint. Joints are messed up. Secondly, what does it tell you about a listing? Could tell you it's already stuck. And that's how we interpret the restrictions, that it's reduced range because it's been used up. So you misalign the joint in the side, in the direction it's been used up. Inferior on the right. Because it should go inferior on the right. So freedom to move inferior on the right. Something's keeping it from moving inferior. Okay? And that's it.